Hello, everyone, and welcome to today's live broadcast, Conversion of Group A Streptococcus Confirmation Testing from Culture to Molecular, Automation Workflow Improvements, and Antimicrobial Stewardship, presented by Dr. Donna Wolk. She is Assistant Director of Clinical and Molecular Biology at Geisinger Diagnostic Medicine Institute. I'm Dr. Susie Valdez of LabRoots, and I'll be your moderator for today's event. We're delighted to bring you this educational web seminar presented by LabRoots and sponsored by Geisinger Molecular. For more information about our sponsor, visit them at www.molecular.diasorin.com. Before we begin, I'd like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. Just click on that Ask a Question box located on the far left of your screen and type the questions into the drop-down box that appear on the screen. We'll answer as many questions as we have time for at the end of the presentation. If you have any trouble seeing or hearing the presentation, click on the Help Desk button located on the promotional board at the bottom center of your screen, or use that Ask a Question box and let us know you're having a problem. This presentation is educational and thus offers continuing education credits. Click on the Continuing Education Credits tab located in the top right-hand corner of the presentation window and follow the process to obtain those credits. Without further ado, please join me now in welcoming our presenter, Dr. Wolk. I will now turn the presentation over to her. Welcome, Dr. Wolk.
Thank you, Dr. Valdez, and welcome to everyone on the phone lines. Today, I'm going to share with you our thought processes and our operational processes as we moved from culture for Group A Streptococcus to molecular testing. And we will start by going through the background, the guidelines that describe the Group A streptococcal testing, Geisinger's population health and stewardship perspectives, and some examples of compliance from our physicians to our recommended testing guidelines. And then I'll give a little peek into what I think may be coming next for Group A strep testing. And we're all very familiar with Group A Streptococcus testing, but its epidemiology is actually quite interesting. We know that in the United States, complications are uncommon and infection rates peak at about 7 to 8 years of age. And the Center for Disease Control estimates that there are about 13,000 cases of invasive Group A strep disease per year, and about 1,600 people will die due to invasive disease. The highest rates for death are seen in infants and the elderly, and there are several million cases of non-invasive illnesses every year. The World Health Organization estimates 111 million children in developing countries get impetigo from Group A strep, and close to 500,000 new cases of acute rheumatic fever, and 15.6 million persons will come down with acute rheumatic fever in the course of their life, of the year. Now, Group A strep sequelae are actually still problematic in Pennsylvania. In a recent morbidity and mortality report, there was invasive Group A strep disease that was tracked to a common source, and that report talked about outbreaks in Utah, Hawaii, New York, and Pennsylvania. So we're especially attuned to the invasive nature of Group A strep. Most people talk about its relationship to the acute rheumatic fever strains. However, the invasive strains are really equally, or if not more important, in our clinical laboratory practice. And to just focus on the acute rheumatic fever is narrow in terms of our perspective for population health. And so we're looking at pharyngitis as a precursor to perhaps more invasive disease. Well, let's talk about pharyngitis. That's the most common thing that we experience: sore throat, high temperatures, tonsillar exudate, cervical adenopathy. These are all very common symptomology, either from viral origin or from Group A strep and other causes of sore throat. The Red Book, the the Pediatric Red Book from 2015 has an amazing scenario of images that describe the different diseases caused by group A strep in different populations around the world, and many of them occur in the United States. And this is the typical sort of sore throat that people see, pharyngitis, but also this cannot be successfully distinguished from some viral sources of sore throat. At Geisinger, group A strep is seasonal, and so we see peaks of strep throat starting when the children go back to school in August, and peaking pretty much almost always with the peaks of flu season, and that is a cyclical circumstance for us. We have increased flu testing, we have increased group A strep testing, and of note, we have 16 large clinic providers, multi-specialty clinics, who are the purveyors of most of our testing and have over 50 tests submitted per month. Now, the purulent complications of group A strep throat usually occur in patients who are not treated with antimicrobial agents. So if someone doesn't get tested, or someone gets tested and has a false negative and they're not treated, this is where the purulent complications can fit in. Group A strep can cause ethmoid sinusitis and cellulitis, which is a fairly painful disease. This picture illustrates bilateral cervical lymphadenitis, and you can really see kind of the chipmunk cheeks, so to speak, causing from the swollen glands from that lymphadenitis from that infection. Now, non-suppurative complications of group A strep are also common around the world, and less so in the United States: acute rheumatic fever and acute glomerular nephritis. This is a 4.5-year-old male with a strawberry tongue of scarlet fever and a rash typical of a group A strep infection. This is these are skin lesions called erythema marginatum lesions on the back of a white male with acute rheumatic fever. This is a 10-year-old boy that presented with something that we call the subcutaneous nodules of rheumatic fever. On the left, you can see those nodules in the inner side of his arm, and on the right, you can actually see a histopathology slide that shows what those nodules look like, the infiltration of white blood cells, etc. And this is called an Aschoff body. Skin and soft tissue infections are also very common sequelae. And here we see group A strep impetigo. We see group A strep facial cellulitis, also very painful as the orbital cellulitis. Here is erysipelas of the left cheek. And then finally, the most severe are the systemic complications of group A strep. This is an example of something called purpura fulminans that occurs with the skin after septicemia or group A strep blood infection. This is a petechial rash from a strep pyogenes or group A strep septicemia. These are called Pastia lines, and these are commonly seen with scarlet fever, which is systemic. This is the circle in blue here depicts a raised skin lesion called erythema nodosum. Here is a picture of a group A strep cellulitis and arthritis in the left ankle, and the purple squiggly lines are not part of the infection. They're just the markings to show the red inflamed area of the cellulitis. This is a picture that actually shows the degradation of the bone from a group A strep osteomyelitis case, and the arrow shows the blackened out sort of non-white areas where the erosion is occurring. And this is a chest x-ray of a bilateral pneumonia and pleural effusion due to strep pyogenes. In our own system, we actually experienced postpartum Streptococcus pyogenes outbreak in the labor and delivery unit, and this can indeed occur in other labor and delivery units. There can be outbreaks of severe strains in hospitals and schools and daycare centers and camps and any place that people congregate. So this is not always an isolated disease. It can be something related to an outbreak or a public health event. Now, there are also some possible links, although they are controversial, and more well-controlled research studies and investigations are needed. But there is proposed associations between group A strep infection and sudden behaviors like obsessive-compulsive behaviors, anorexia nervosa, and tic disorders. And this is perhaps maybe the most controversial, the pediatric autoimmune neuropsychiatric disorders associated with strep infections or PANDAS. So keep your eyes on the literature for more emerging information about these associations. And finally, even sort of larger than a systemic infection is the triggering of the superantigens or the streptococcal toxic shock syndrome and necrotizing fasciitis. This is the hand of a 14-year-old male with group A strep sepsis, who then went on to develop the scalded skin cyst syndrome and the desquamination of his skin. This is a necrotizing fasciitis case and the inside arm close to the shoulder from group A strep. So I don't need to convince anybody. It actually is a good reminder, though, to realize that although we commonly see group A strep associated with strep throat, it actually has much more severe complications in many mostly untreated patients. Now, what do the guidelines, the clinical guidelines, tell us about laboratory testing or about preclinical assessment of group A strep and testing guidelines? Well, the College of American Pathologists actually favors the backup of negative rapid antigen testing, or RADTs, for all ages. And the rapid antigen test is really the more really common kind of physician office lab test that occurs at the site of presentation at the point of care or near the point of care. And it is an antigen-antibody reaction, and color develops if there's an antigen-antibody that combines and the color is bound and you see a positive reaction. The CAP recommends backing up the RADTs with a culture or additional tests because of the declining accuracy and susceptibility of many of the rapid antigens over time. Now, PCR is not specifically addressed in the CAP micro inspection question number 22140, but it definitely can fall under what they call other tests. And in that respect, it's been our perspective that we would move to that, and I'll explain why as we move through the presentation. There is a consensus document in the Pediatric Red Book. 2015 is the latest version of that. And there is a pediatric consensus for testing children in the United States. They say laboratory confirmation is required in children without viral symptoms. So they're conceding to the fact that if a kid has a flu A test, then maybe that's positive. Maybe they don't have strep throat. But we know that we do get positive combinations with strep and flu during the flu season. They also recommend that you collect samples by vigorous swabbing on both tonsils and the posterior pharynx. And they do also say that negative rapid antigen tests from children are cultured. They cite that the false negative culture rates occur in less than 10% of symptomatic patients when an throat swab is obtained. And that was actually true when the first rapid strep test came on the market. And if, I think when is not the right word, but if the specimen is adequately contained, because as you'll see later on, if a specimen is suboptimal, the accuracy rates can drop from 80 to 90% all the way down to 56 and 80 to 86%. And that varies widely by the provider and whoever is collecting the sample. European guidelines for strep pyogenes have an overall consensus against the backup culture. If the rapid antigen is performed, throat culture is not necessary even after a negative rapid antigen for the diagnosis of group A strep in children and adults. Their guideline does, however, point out that other organisms like strep group C and G, beta strep, Mycoplasma pneumonia, and Chlamydiophila pneumoniae can also cause sore throat, as will viral antigens. So that's kind of 2 for and 1 sort of against, or blatantly against. And the last one we'll talk about is the Infectious Disease Society of America, which is both for and against. There are some contradictions when you read through the entire guideline. So they say that in children and adolescents, negative rapid antigens should be backed up by a throat culture, and that recommendation is strong. They do not mention PCR. They also say that routine use of the backup throat culture for those with a negative rapid antigen is not necessary for adults under usual circumstances, and that is also a strong recommendation. And they cite the low incidence of group A strep pharyngitis in adults and the risk, which is low, of subsequent rheumatic fever, which is generally low in adults. We know that. However, then they go on to say that physicians who may wish to ensure that they are achieving maximal sensitivity may continue to use conventional throat culture to back up rapid antigens. So they're leaving the door open for the providers to really determine when they should or should not back up a negative rapid strep test. And here they're really only talking about cultures. Furthermore, IDSA talks about diagnostic studies for group A strep pharyngitis are not indicated for children less than 3 years old because, again, acute rheumatic fever is rare. We all agree with that. Acute rheumatic fever is low in the United States at this moment. But then again, most U.S. laboratories are backing up a negative testing and catching the false negative or the false negatives with some kind of a culture or PCR. And so, labs are following the CAP guideline. Whether or not that's associated with our low acute rheumatic fever prevalence, no one really knows. It could be strain related, it could be testing related, and but nevertheless, it's higher around the rest of the world where backup is not as consistently performed in the States. The other thing they say is that children less than 3 years old who have other risk factors, such as older siblings, may be considered for testing, despite of the former recommendation. And it's been a while since I've been around lots of 3-year-olds, but I still think there's very few of them who aren't in some kind of contact with older kids. And so, this doesn't give us a whole lot of guidance for our laboratory perspectives and our initiatives in the laboratory, but nevertheless, that's what's out there. And I close this section with the rheumatic heart disease map. You can see in 1970 to 1990, the white sections of the map are places where acute rheumatic fever was low, and the darker sections where it is higher. Compare that to the bottom map, which depicts 1999 to 2011. We still see a lot of white areas. We see some changes in areas. We really don't know if this is due to strain differences emerging in different parts of the world or different testing and reporting patterns, but nevertheless, the United States remains relatively low in rheumatic fever. Now let's talk about, so then, the guidelines are, we know the disease is severe. The guidelines are a little bit vague and open-ended, so what is a laboratory to do? Well, we look to our mantra, I guess, is kind of the word that we use to describe population health and antimicrobial stewardship for our patients. And from population health concepts, we know that invasive group A strep disease is a much bigger risk for us than acute rheumatic fever. So we're really focusing on invasive group A strep that is associated with many of the things that we see as common chronic or comorbidities or chronic conditions in today's patient population: diabetes, skin breakdown of the elderly, heart disease, smoking, cancer, alcoholism, immunosuppressed IV drug use, and dialysis. So in our perspective, population health is defined as the health outcomes of a group of individuals, including the distribution of said outcomes within the group. So we're looking at not just the patient that we're testing, but in our area, we also insure and care for many of those same family members, many of those same community members. So we also look at what's going on in a community and what's the role of testing above and beyond what we do for the immediate single patient. So our aim is to prevent invasive disease, which is high impact and high cost. And from our perspective, the issues are not the traditional sequelae of group A strep, but rather the invasive infections, necrotizing fasciitis, group A strep, bloodstream infections, wound, and skin and soft tissue infections. And if you look at the epidemiology of invasive group A strep, then what do we see? Well, we see that if we look back to the guidelines, kids less than 1, and 2 to 4, where they're saying no need to test these people unless there's an association with older children, they actually, start out relatively high for invasive disease. If they're carriers, they may have cuts. They're putting their fingers places maybe they shouldn't be putting them, and so we do see that. Then it kind of dips in the years that we're testing everyone, and then it swoops back up again as the population ages. So while the strep throat may heal on its own, the sequelae associated with invasive disease increases with age, and all of those comorbidities we talked about in the previous slide. From an antimicrobial stewardship population in our outpatient, we rely on both viral and bacterial testing, especially in the elderly and chronic diseases and in children. Physicians often use antibiotic treatment for sore throat, which is not related to group A strep. We know that. The combination of having a viral test and a group A strep test is useful to our stewardship approaches. And our goal for population health is to use the most accurate and sensitive assays so that our physicians can actually rely on the laboratory test result and not have to guess. Is this a false negative? Is this a false positive? What am I actually dealing with? And there's intense pressure on particularly pediatricians to prescribe something when a child and their parents come into the doctor's office. So having that accurate test information is actually a good countermeasure for them to be able to say, look, I trust the results of this test. Your child does not need antibiotics at this time, et cetera. And for us, the answer to that is PCR because it's the most sensitive assay. And again, while culture misses around 10% of the true positives, for most PCR assays, you'll see we find that that's somewhat higher. And that is probably due to the fact that screaming children are very difficult patients to get a good throat sample from. And so we see that wide variability of accuracy based on sampling populations. Now, we were challenged by our insurance company of why we were doing molecular testing when it's not even required to have culture confirmation by some of the consensus guidelines. But we pushed back with a letter that says, well, they are consensus guidelines. We submitted the information about the increasing invasive group A strep disease in the aging and comorbid populations. And we printed a summary of the points of our letter in this Clinical Microbiology newsletter, which is available online and probably from multiple vendors of group A strep PCR, where we focused on those concepts. And I'm happy to say that as of 2014, our insurance companies, including our own and not our own products, are actually reimbursing for this testing. And so this is available for others who are facing lack of reimbursement. The cost of several invasive diseases easily eats up more than what it takes to test with a low-cost PCR for group A strep. And as I alluded to before, we also made the case that while rapid antigen tests were originally greater than 90% accurate, now false negatives are very common. They're still fast, but sensitivity ranges from 56 to 86, and it varies with the provider. How did this occur, and why aren't people picking up on this? Well, bacteria mutate, and an antigen test picks up what it picks up. And so if it started out missing 10% of the strains in your particular community, like they did when the FDA released them many years ago, then the strains that are missed are going to become the strains that perhaps then circulate in your community. So you have that pressure, plus they just change for no reason. There's a lot of people that follow the streptococcal strain, and when those strains change, the antigen testing is very slow to adapt if there's a mutational change that causes a protein. The same thing happens with PCR, but the primers are easier to adapt than making a brand new antigen for an FDA-cleared test. And so, this laboratory testing pressure of getting rid of the things that we can detect as positive and leaving the things we can't detect as positive, and those infections then spreading from people to people, is a consequence of it's just what happens in a community. So we made that case as well. And recent publications here for you that are outlined in the Clinical Microbiology newsletter and afterwards give you some quite good information about the loss of sensitivity and accuracy of the rapid antigen test. So there's clear need for some kind of a backup, albeit culture or PCR. Then University of Washington, Ferric Fong and Tanis Dingle had a really nice report where they did a retrospective analysis of almost 1,000, over 700 adults greater than 13 years of age, and they actually follow these people to show the benefit of testing the negatives, the rapid antigen negatives, and finding the cases, allowing them to return to work more quickly and reducing opportunities for invasive disease. So that's also another good reference. Now, how are physicians doing following our guidance? Well, our provider compliance is actually pretty good, better than I thought it would be. And so 17% of tests are actually positive, and most of them are tested and positive, and a few slip through the cracks of, being coded as strep throat, but no test was ever performed. But most of them are tested. That accounts for the first 17%. And then all of the rest of the pie chart comes to us in the laboratory. And so of the total, we find 10% more on top of the 17% of the positives that really were pulled out by the rapid antigen. So it ends up being much more than 10% of a difference between the rapid antigen. If we were to look at that, we do have data on that. And then 73% of the whole remains negative even after the PCR testing, proportionally. And in our pediatric sites, what we see and maybe I shouldn't say much more, but let's say some more, we range between 6% and 18% of the negative rapid antigen samples we get actually do come up positive, and that ranges, it's a little bit higher in the pediatric sites, and also these are not adjusted for sample size, so some of the sites are actually contributing low numbers, and that may vary. But we actually still see some mixed peds adult sites that still have that 18% positive. So we feel like we're offering a good service, picking up, at least 5 to near 20% more on top of the already positive sort of 17% of the samples we see, getting those people proper treatment, stopping the spread of group A strep in our communities, and transmitting it to other family members and schools and the like. So we do quite a bit of group A strep testing, and we need it to be fast, even the backup to be fast, not just the rapid antigen. And so the next part of this, I'm going to describe how we verified a laboratory-developed test with a GAS, group A strep ASR, and the Janus pipetting system for the diasorin strep PCR, and this was an abstract at CVS several years ago. We use the laboratory-developed test right now on the PerkinElmer Janus and the Liaison MDX instrument, formerly the integrated cycler. And I want to point out that this is a laboratory-developed test because we're performing this on the robot, which is not part of the ASR package. And so part of the reason why our insurance company pushed back on us was because of this LDT comment that we put in our results per the CAP recommendation. Nevertheless, we felt it was still the right choice for us. And the assay has the usual master mix, primers, internal control, and molecular water. The instrument is the Liaison MDX. The Simplexa extraction and amplification control is used along with the group A strep primer pair. And in this assay, extraction and amplification occurs at once. There's no separate nucleic acid extraction step, and the robot does all the pipetting for us. Our initial study design was actually looking at the old group A strep DNA probe versus culture versus the now diasorin strep test. We actually collected a special swab that COPAN made for us here, pictured in the left, because we realized if we verified the new test on an e-swab, which would have been ideal, then we didn't have the right swab for our clinics to perform the rapid antigen. So COPAN made a dual swab, one of each. One is used for the rapid antigen, which keeps it as a wave test and keeps it on label. The other swab is placed in an e-swab and then sent to the laboratory for testing. So, and they will provide this swab to you and other customers. I understand lots of people are using this now for the same reasons that we asked them to develop it. So it's actually a nice way around not messing with the CLIA waiver for the rapid streps. So why did we choose an LPT and to go through all this trouble? Well, we have high test volumes. We found that automation can help us reduce entry errors. There's less steps. And this custom swab was really the key to how we could pull this off in our large sort of 10 hospital, 45 county footprint for our population. What we found was we had improved performance over the DNA probe by quite a bit. And when we first looked at it, it looked like the PCR positive predictive value was quite low. There were a lot of false positives. When we actually arbitrated that with culture, for the most part, we had enough sample to arbitrate that, we came out with very good accuracy, analytical sensitivity, and specificity numbers that you can see here under the arbitrated column. So performance was quite good. The 90% limit of detection was determined to be 1.5 times 10 to the third CFUs per mil, and the 95% limit of detection lands somewhere between that 1,500 and 15,000 CFUs per milliliter. Comparing equally well and still better than the culture methods that were used in the comparison. Our mean age and gender of our population was kind of interesting because it did kind of parrot what we're seeing with the CDC guideline for when you have invasive disease and when people might be testing. So our providers are actually kind of picking up on that. We're peaking in the pediatric age, and we have a bimodal distribution where we're peaking again with samples between 50 and 60 years old. Maybe they're testing their throat while they're testing their skin samples, et cetera. And we had a mean age of 27.2. And when you do your verification, it's kind of important that you do test in the population that you're actually going to be testing in to whatever end you can. We do see an increased female percentage all the time because of the caregiver type of relationship and the close contact with females. So there is kind of a skew for females in the group A strep world. Our reproducibility was also very high. The standard, the variability over 20 different days was only 0.2 log, which is typical for extracted PCRs, and we were quite pleased with this. This just shows the cycle threshold distribution, which was really a normal shaped distribution, and we tested the both the group A strep positive control and a group B negative control was negative during that time. We tested a large variety of both viruses and other bacteria found in the throat and found, nearly 100% specificity. Analytically, I believe it was 100%, and then with the clinical samples, similar performance. Additional things we looked at was carryover and contamination. We had none during our testing period, and this was years ago. We still have never had a group A strep contamination event in our laboratory. There were no interferences observed when we looked at our internal control, or some people call it the inhibitor control, so we didn't have a lot of matrix effect, and that shows by that tight precision when we're looking at the internal control and the cycle threshold. We saw good specimen stability, 72 hours at room temperature or refrigerated. With e-swab and with the dry swab, even if people, and they sometimes do put the wrong swab in the wrong thing, then we have to cancel the rapid result. But we verified the dry swab as well. We have a smaller window of stability, less than or equal to 24 hours at room temperature or refrigeration. And then we cross-validated all the cyclers that we have in our cycler bench for cross-instrument verification. So in summary, we were able to show sensitivity of 100% with the arbitrated samples, specificity of 98.2, and a total agreement over 98%, and showed to our own cells that it's possible to automate this assay. And using the Janus robot pipetter. Now, I will say that when the Janus pipetter works, it works very well. When there is maintenance or downtime, the support for speed, because of it being more of a sort of a research-focused company, is not quite where we would like it, and I'm just being fully transparent. We are happy that there's a new robot coming from DiaSorin that may have more of a clinical maintenance type of turnaround time and downtime parameters. We're also happy that Group C and G strep beta hemolytic is coming. And we do know that we have about 6.5% of our sample. We were involved in a kind of an epidemiology window assessment where we found that 6.5% of our negative samples actually had group C and G. We know that that can be a normal in a carrier population, so can group A strep for that matter. And so it's just another piece of information that we're hoping to add. In this small sample set, we found that most of the people that were positive had symptomology of sore throat, fever, headache, fatigue as the top symptoms. Yes, this could still be viral, but in combination with the viral testing, it may provide information, particularly for immunocompromised and other compromised patients with comorbidities, where this might be an important thing not only for the strep, but perhaps for subsequent invasive skin infections, which we know these organisms will cause. And then finally, we looked at many different options for our PCR testing. So there's an Illumagene method, AmpliView, Group A Strep, and they have C and G by Quidel, the Alere, Strep A, the Roche Molecular Liat, the Quidel Lyra, Simplexa Group A Strep Direct. The accuracy in terms of analytical sensitivity and specificity are all good. The turnaround times vary, and so everybody has to pick what they think works best for their system. There's a number of choices that you can pick from if you're interested in converting from culture to molecular methods. And then finally, what are we looking at in the future? Well, we're looking at other things besides Group A strep, peritonsillar abscesses, Lumera's disease, and Fusobacterium, Vincent's angina, and what do we do with throat cultures from people that have severe comorbidities, immunosuppression, or a history of a rheumatic fever? Do they need strain typing? Do they need extra things that we would collaborate with the Department of Health? We also look for a sore throat after travel in Europe in particular and other parts of the world where there have been some rare diphtheria strains that are not necessarily those that produce diphtheria toxin in the classic sense, but they do cause severe sore throat. And so this is a nice review that I'll close and leave you with in the CID journal by Schulman et al. That goes through a list of the other bacteria. CG, Group C and G beta strep, we'll be testing for. Our Canobacterium we do test for in our throat cultures and hope to automate that in a molecular assay. Keeping our eye on the literature for Corynebacteria diphtheria strains, and of course, an easier way to detect Fusobacterium and other anaerobes. We only get the tip of the iceberg for Fusobacteria, those that have developed Lumera's disease, but there's probably a higher population that perhaps we don't know about. And although rare, bioterrorism agents like Francisella and Yersinia can cause sore throat. And then combining that with the other microbes, we know the viruses are associated, Mycoplasma, Chlamydiophila, and yeast. So our future goal is to pick the most sensitive and comprehensive assay as possible to support our population health initiatives and to improve our patient satisfaction ratings for our providers in the field. We know that when we can give a diagnosis, people go home happier knowing what they have than if they go home still not knowing what they have. And so with the Press-Ganey scores and everything that we're doing, it behooves us to try to make a diagnosis. And in some cases, there's actual reimbursement issues for an infection that can be identified versus those that cannot be. And so that's something important to look into your local region because that varies sometimes region to region. So I thank you for your kind attention. I thank you for your interest in Group A strep and all that it has been and will be. And I'll close this session and take any questions you may have. Thank you very much and have a great day.
Thank you, Dr. Wolk, for that informative presentation and for your important research. We will now start the live Q&A portion of the webinar. If you have any questions you'd like to ask, please do so now. Just click on that Ask a Question drop-down box located on the far left of your presentation window. Type your question into the box that appears on the screen and click the Send button. We'll answer as many questions as we have time for. So let's take a look at our incoming questions from our audience. Our first question, Dr. Wolk, is what are your thoughts on using molecular method as a first-line strep test rather than a confirmation test?
Well, I would love to be able to do that. We actually have some molecular instruments out in our field sites, so to speak, our large physician office practices in the community that may be adaptable for molecular group A strep testing. And so we're looking at those as possibilities. All of those sites right now have medical technologists, and so we have piloted molecular testing with them in the community, and they're doing very well. Our next step is to kind of try to understand if we moved it a step further, and what we're thinking of is the phlebotomists who are doing home health care or who are there in the smaller clinics where there's no medical technologist who may be able to take a throat swab from a nurse collect and actually run the test. We find that we have very good compliance with point-of-care testing with our phlebotomists, and it doesn't seem cost beneficial to have a nurse or even a pharmacist to do point-of-care testing when our phlebotomists actually do a much better job. So we're trying to keep the laboratory focus, let the providers do what they do, and then we're looking at on-site group A strep testing in the future. We don't really have that nailed in to what platform we might be using yet, but it is definitely something that we're considering. And you know, we really have to look at the cost and the economics of doing that. We've had a lot of success with our on-site flu testing in reducing the inappropriate number of prescriptions for anti-influenza, and we hope that we could pilot some other programs to look at doing that for inappropriate antibiotics for group A strep. So there's a lot of things on the horizon, and we're looking at the literature and our own pilot processes to make a final decision on that.
Thank you so much, Dr. Wolk. Our next question coming in, why did you validate an LDT instead of using an FDA-cleared molecular test?
The thing for us was the ability to batch and roboticize the process. So we do over 30,000, close to 40,000 group A strep tests a year, and those are the ones that are negative. So we have a very high volume. We run that test 3 times a day with couriers that are delivering specimens every 4 hours to the central laboratory. And so we test twice on second shift and once in the morning so that when the providers come into the office the next day, their backup tests are there and ready for the phone calls to be made to the patients. So it was really a volume and automation type of decision, and the culture processes are just too slow for people anymore. From our perspective, we get a lot of patient dissatisfaction waiting for the incubation to occur. And also, we were using the old DNA probe before. We were already doing molecular testing, and that was running its useful life and kind of sunsetting, so we needed a new tool that was high throughput, and we chose the PCR. And in terms of verifying the LDT, we're very comfortable verifying that. And you know, it is something that you need to talk to your insurance providers about. Once we gave them the data to support it, they actually agreed that it was a good idea in our setting. And so each geography varies.
Thank you. And I also want to thank our audience members for their incoming questions and remind them that any questions not answered today will be answered via email. We have time for a couple more questions. Here's our next one. How do you justify the higher cost of molecular testing compared to culture?
Well, you know, when you actually do the math on a method like this that doesn't have the cost of extraction built into it, and you consider all the hands-on times that occur when a strep is looked at, perhaps subculture, maybe a latex test, and you put that all together, the high throughput of this actually makes the cost not as prohibitive as you may think. Now, in terms of the former question is, would I like to just have this be the primary test? Yes, because, the rapid antigen is an additional cost, and while it's not a huge cost, it would be nice to just standardize and pick one test and move forward. So we really haven't got any major pushback in terms of reimbursement from the insurance companies that we work with, and so we're not really passing this on to the patients in most cases. We do have a caveat for people that perhaps are uninsured and can't pay, and we can sometimes make accommodations for that. But the cost of this test isn't very high compared to other molecular tests, and so really don't come across that. Plus, many of our people are covered with insurance in our region because of the low-cost health plan that we offer, which is more preventive, and so we don't have a huge proportion of uninsured patients in our population. Again, that varies by geography.
Right. Thank you. We have time for one more question. Do you test group G and C strep with group A on all samples, or are they ordered separately?
That's our intent moving forward. We don't at this time. We still offer a throat culture for group beta hemolytic, group C, G, Arcanobacterium, and other bacterial pathogens. And in cases of Lemaire's disease, we will do an anaerobic culture on a throat. But all the differences in methodologies is a human cost for our technologists, and we hope to be able to put them all together as best we can and try to keep the price at a price point that is not going to be onerous to our patients, because for the people who are aged or have comorbidities or could be experience a sore throat by these alternate pathogens, it would be better, from my perspective, to have a one-and-done syndromic panel where we could test for all of those, and that's what we hope to be able to do in the future.
Dr. Wolk, thank you again for your presentation and for your important research. I'd also like to thank Geisinger and Molecular for making today's educational webcast possible. Before we go, audience, I want to remind you all that today's webcast will be available for on-demand viewing through July of 2018. You'll receive an email from LabRoots letting you know when this webcast will be available for replay. Please share that announcement with your colleagues who may have missed today's live event. That's all for now, and thank you for joining us today. We hope to see you again soon. Bye-bye.